Hello everyone, Ruth Myers here. This seminar is going to talk about a slightly agitating topic, which is psychotropic medications. Many bits of controversy all around in terms of what's the right way, if there is a right way to offer people psychiatric medicines. A lot of confusion about what's treatment versus what's something else. And in our time here today, I'd just like to talk about some of those controversies and also talk about some specific examples of different medicines we might want to consider offering to somebody depending on what kind of a condition they have. Probably the biggest controversy that I run into and the biggest confusion I run into is people not really understanding the difference between health-promoting psychotropic medication use and chemical restraint. And people also, understandably would say, well, there may be a difference, but does it matter? And I think it does. So let's start there before we start talking about psychotropic medicines per se. And this is a quick comparison. The thing where people roll into the emergency room and they are becoming agitated and somebody injects them with a medicine to make them fall asleep, that's an emergency medicine. That is a chemical restraint. That's not health promoting psychotropic medication use. And there is even some research that says that in fact may be more dangerous than people realize. But one of the reasons that people get away with it in emergency settings is that they have the capacity to monitor people. I saw somebody the other day who's at a state of illness where for her to be safely treated for the amount of mania she's experiencing and the number of co-occurring health problems that are making it worse is probably going to require a setting where they can do telemetry, which is where they monitor the person's heart to make sure it's still beating. That is one extreme of psychotropic medication use in an emergency fashion as a chemical restraint. I don't advocate that, obviously, and I certainly don't advocate that as an ongoing plan. Yet, as we talk about the differences, let's think, are any of the people that we support really being put in chemical straitjackets rather than receiving health-promoting psychotropic medications? When people are getting health-promoting medicines, their physical function improves. They don't feel sluggish, they don't feel dragged out, they don't have a hard time walking. Whereas chemical restraint restricts physical function. In fact, that is the reason why it is used, typically in certain emergency settings. And I'm not endorsing that, I'm not supporting that, I'm just illustrating how medicines used in that way are a restraint, not an ongoing health plan. Health promoting use increases a person's strength and power, and chemical restraint does the opposite. The benefit is sustained with a steady dose. In health-promoting use, people discover the right amount of antidepressant to treat the depression, and they can usually, unless there's other complications, they can usually stay on that dose for as long as they need to be treated. Whereas when medicines are being used as a chemical restraint, basically for their sedating side effects, for their ability to incapacitate people, that incapacitating effect tends to wear off. And people have ever increasing doses until the doses become extremely dangerous. Health promoting use supplements a physiologic need. And some of you are already very aware of some of the really wonderful neurophysiology and other kinds of neurochemical work that's being done in understanding brain chemicals that help the brain talk to itself and to the rest of the body. How sometimes a person can be a pint low or a quart low or a pint too high in certain chemicals, and it will alter their mental status in a way that's frightening or dangerous. Those are the types of imbalances that we'd like to address. And health promoting use is easy to see as a direct comparison between people with severe diabetes that need insulin, you've all heard that analogy before, or various other conditions where a person has a physiologic need and they get a certain correct dose of medicine to supplement that need. Probably, and in terms of chemical restraint, it's not supplementing anything, it's adding sedation. It's adding sleepy time chemicals to the person's body. Probably the most important feature between health promoting use and chemical restraint is that when a person is on the psychotropic medicines that are used in a positive way, they feel like themselves. I can be myself again. That's an example of a healthful use. Whereas people otherwise describe feeling foggy, confused, sleepy, disengaged, intoxicated, and unable to function when they're in the midst of chemical restraint. The other thing I'll mention about chemical restraint is that there's this idea that some people have. What does this caption say? What's the name of that tranquilizer we use? People get this idea that you get injected with a few sleepy time medicines and you kind of feel like you're in Shangri-La and it's like the most fabulous thing on earth. It's like a super buzz without calories or what have you. It's not really how people describe it later. Most people don't like the idea of somebody drugging them into compliance. Most people don't like the idea of, I can't physically function, I can't defend myself. Particularly people with a trauma history often very much feel re-traumatized when they are given a medicine that's purely to slow them down and impair them physically. So one way that most of the rest of the world gets to think about psychotropic medications, as in treatments for depression, treatments for schizophrenia, treatments for what have you, is that there's lots and lots of drug studies out there. So the question is, are there any really good drug studies, or where can we find the great drug studies that guide us in terms of what psychotropic medicines to offer to people with intellectual and developmental disabilities? You'd think there would be, right? Since so many medicines are being advertised and promoted for people with IDD, aren't there drug studies to guide us? And the answer is yes and no. Now, didn't that sound like a psychiatrist talking? Well, yes and no. But it's kind of the thing. It says meaningless statistics were up 1.5% this month over last month. Some data are helpful, but most aren't. So when you say, well, didn't this article say that Risperdal treats autism? Well, in fact, that is absolutely not what the article says. However, that is how the article will be promoted when the company that makes Risperdal is trying to sell their medicine. Most general studies of psychotropic medicines to treat specifically diagnosed conditions like depression, schizophrenia, bipolar disorder, most of those studies do not include people with developmental disabilities as study subjects. In fact, some of I take this course every couple of years or so, which is supposed to be the master psychopharmacology class, where all these people that have written all these really important books say what they think. And almost every one of them says the biggest problem with almost all psychotropic medicine studies is that the patients they're treating are nothing like patients in the real world. So instead of saying, let's do evidence-based practice, which means we practice according to what the studies tell us, they strongly advocate practice-based evidence, which is, what do we learn about treating real people in the real world? And that is different, oftentimes, than what those early drug studies show us. And so drug studies specific to condition, medicines to treat bipolar disorder, medicines to treat obsessive compulsive disorder, those kind of studies are a good place to start. If we can look at a study and say this didn't help anybody, well, that's good to know. Maybe we'll steer clear of that one, unless there's a physiologic reason for this individual patient to offer them that medicine. Most of the psychotropic medicine studies that focus on people with intellectual and developmental disabilities are talking strictly about chemical restraint. They're not talking about specifically diagnosed conditions. It's probably the biggest issue, is that they talk about vague symptom categories, XYZ drug used to treat aggression. Well, there's that in-between thing where we got to figure out the cause of the aggression. Otherwise, it's purely chemical restraint. Or they use diagnoses that don't really mean anything, like intermittent explosive disorder, which is kind of like calling the flu intermittent vomit disorder. It's not a real diagnosis. It doesn't tell you. What's the test of a real diagnosis? It tells you how the person is feeling, and it gives you specific ideas about what to do about it. In my few years looking after people, I found that everybody who came to me carrying a diagnosis of intermittent explosive disorder had something else. And when we really understood the something else, we could offer the person much more effective treatment. In drug studies that include people with developmental disabilities, the point of view of the actual person is never listed, which is a big, big problem. They might ask caregivers and family members, well, did he seem to have any side effects? Which is useful information, but it's not the most important information, is it? Some of the writings by people with autism are really, really firm on this point. And some of the writings about other people with other disabilities is, what you think is helping me may be making me feel horrible. You gotta ask me. The real sponsors of the studies are typically hidden, or often hidden. There's a couple of pharmaceutical companies that are particularly corrupt in this regard. For example, one drug company heard that I was not going, when I was teaching a continuing medical education course to physicians about psychotropic medicines, this one pharmaceutical company had heard in one, their representatives had heard in one of my other lectures, I had said uncomplimentary things about the medicine they make. So they sent people to my seminar posing as students to try and drag down my evaluation scores. That's the degree of corruption. And I would not have believed that, except I made friends with the gal who collected all the evaluations. She said, yep, these are the ones from the drug reps from this pharmaceutical company, and they're quite a bit different than all your other evaluation scores. So it's hard to overstate the amount of corruption that is present in some pharmaceutical companies, but not all of them. The other big problem is that a lot of studies are hurried into the literature, and for all kinds of logistical reasons, but it's still very, very important to have that awareness that what we see in the first month or first year might not have much to do with what we see after that. And some just work very, very hard to avoid listing some of the more serious long-term side effects. And I'm looking at you, Depakote, which unfortunately has been marketed for everything on earth, but in fact, over the long term, has some really pretty terrible side effects. One of the reasons why Depakote was so slow to issue what's called a black box warning, which is a life-threatening potential side effect that every prescriber should be looking out for. Depakote can cause something called hemorrhagic pancreatitis, and what that means is the person will develop an irritation in their pancreas, the place where we make insulin and stuff, and they will develop a type of irritation in the pancreas that starts to bleed, and people with hemorrhagic pancreatitis can bleed to death in a matter of minutes to hours. And that is a rare but obviously important side effect of Depakote. And the first patients that were reported to have this side effect were people with developmental disabilities. And the makers of Depakote said, well, those patients don't count. So that's why we don't need to warn people to take this medicine. That was eventually overturned, and sure enough, valproic acid, which is the generic name, has a black box warning for hemorrhagic pancreatitis. The other thing is, many years ago, I was a substitute transplant shrink on a transplant team, which is very interesting. And I was impressed that the first 3 people I saw needed new livers because Depakote had killed their livers. And at that time, people were not being very diligent or being encouraged to be very diligent about monitoring the effects Depakote has on liver, bone marrow, pancreas, kind of important doodads there you got going on. And I'm really kind of jumping all over Depakote, aren't I? Well, you remember those first few patients that had hemorrhagic pancreatitis from Depakote, where they wanted to suppress the results? A couple of them were mine. Definitely got my attention. It's shocking, just shocking. So there's this gal. I wish I could show you her picture because she's just remarkable to look at. Her nickname was The Tank. 36 years old. She probably comes up to about here, up to my shoulder, and built like a fire hydrant, just really small and fierce. And although she doesn't look like she could do it, she actually throws people around pretty efficiently. She also had been blinded, and we were told that the blindness was a result of the long-term use of a medicine called Thorazine, which is one of the very first antipsychotic medications. I said, well, how did she end up on a dose of 2,000 milligrams a day when the max dose of Thorazine was supposed to be 600 at most? And this was because she, in fact, never had symptoms of schizophrenia. It was being used purely as chemical restraint because from the time she entered the facility, when she was 16 years old, she had this thing about putting people in certain places and putting furniture in certain places. And she happened to live with 7 other people. It's a group home model that often doesn't succeed. But in a way, it was sort of a good thing with her because she had a very clear mission in her mind that this person belongs here, this person belongs here, this sofa belongs here, and she was very, very fierce about it. And they called her the Tank because nothing could stop her. This only happened in her house, which was interesting. She had a job. She had a job helping to stack firewood. She loved doing that for some reason. She communicates without speech, and is thought to have profound intellectual disability. In fact, at 2,000 milligrams of Thorazine a day, I'm amazed that she could stand and walk. They said, well, it's really done a good job reducing the behavior. Is that because she's now sleeping 18 hours a day, so she's not awake as many hours? to engage in the behavior? Yeah, that's pretty much what it was. Well, the people providing support to her cared very deeply and thought, this can't be right. This medicine is such a high dose. She's sleeping a lot. She's blind, and we hear it's from this medicine. We need to do something about this. We got to do something else. And so the first question, does she have a reason to be on this medicine? What are the reasons a person should be on Thorazine? Schizophrenia or acute intermittent porphyria? She had neither of those problems. Well, and then we want to say, well, why does she do this? And some people say, well, it's just a behavior, which is shorthand for we don't have the time, energy, bandwidth to figure it out. Well, let's just back up a second. What is it when a person tries to recreate a situation and they can't let go of it? They just can't let go of it. What might that mean? The other thing we had was this local ophthalmologist who was supposed to be the great expert said, well, why should we bother trying to restore her vision? I mean, what does she need to see anyway? One of those, we've talked about this in many seminars, where a person who may be very skilled with the ordinary population may not have the same heart and soul for people with IDD. Well, how can we find out? What started all this? Well, one person said, well, she didn't come to live in this house until she was 16. Maybe she did that her whole life, or maybe it just started. That'd be useful to know, wouldn't it? So what's the story? Well, it turns out she came from a really big family. And when both of her parents became gravely ill, the recommendation in those days was that, well, you got to get rid of the kid with the developmental disability. That's just another stress that you don't need. So the advice in those days was typically followed by, after you get rid of her, don't have any contact with her. She'll forget about you. You'll forget about her. It'll be like she never lived. So at the age of 16, she was sent to this 8-person group facility where she's lived for the following 20 years. Not much was written about what her life was like before she was moved, other than she came from a big, lively family of a certain ethnic heritage. Well, we need more information, don't we? Well, it turned out that there was one sibling we could find, and she felt as bad as probably the tank felt. She said, it didn't seem right to just send away our sister, but that's what they told us we had to do. I said, well, we're wondering what's going on with her now. Can you come by and visit? Oh yeah, I'd be happy to do that. She came by, it was an amazing reunion, and she looked around at where this gal had put the people and the objects, and she said, oh yeah, that's our house. So some people want to say, well, didn't she do this because she's blind and needs to know where stuff is? No, this started way before her vision had been destroyed. So when somebody has suffered a catastrophic loss and they keep revisiting it with every single molecule of their feelings and actions, that's called a grief reaction, isn't it? A complex bereavement, a complex grief reaction. Do you treat that with drugs? No. If you put somebody in a semi-stupor with sedating medicines who's in the middle of a grief reaction, what does that do for their grief resolution process? It stops it, right? So she's been in the midst of this sudden, acute grief and loss cycle for 20 years. and she feels crappy from the medicine she's getting, and she's been blinded by it. So what's the correct treatment for complex bereavement? Psychotherapy. What's the correct thing to do about this Thorazine? Well, we can't just stop it. Her body's adjusted to it. So we have to change that very, very slowly. Otherwise, the withdrawal effects will be even more miserable than the direct effects. So the correct thing to do is to reduce the Thorazine by 10% of the total daily dose every 4 to 8 weeks. It takes years to do it properly. But that's the kindest thing to do to her body. And you know, it's kind of funny, people say, why don't you just put her in the hospital and yank it off? And I'm like, doesn't feel any better when you do it that way. Plus you're in a hospital, which is often not very much fun either. So the kindest thing to do, if you can, if it's not a toxic allergy, is to reduce the medicine very slowly. And if she needs psychotherapy, how are we going to offer it for a person who communicates without speech who's also blind? Well, some people, of course, want to say, well, you can't, can you? Well, of course you can. You got a lot of other senses going on. First thing, and some people were skeptical of this, and it's okay. You know, skeptics might turn out to be right. But the skeptics said she'll never understand that when her sister recorded for her, and this is so long ago, we're talking cassette tapes, recorded for her the story of what happened, as well as an apology. We're so sorry this happened. We miss you, sister. And they're like, she's not going to care about that. She wore out 5 copies of that audio tape. Well, what else can we do to help restore her sense of connection and family? Well, like I said, very lively ethnic tradition, wonderfully fragrant ethnic foods. Can't see? Well, we can restore some of that. And each time she got to eat some of the food she grew up with, she could experience memories, she could experience and express sadness, and eventually come to enjoy having this restored in her life. Well, people are saying, you know, that's nice, but what does it do? I mean, does it make any difference? Well, within 2 weeks of getting the audio tape and starting to eat those wonderful Hungarian foods, all this shoving people around stuff stopped. We found a different ophthalmologist who said, well, it doesn't matter what I think. It matters what she might want. So, of course, let's try and restore her vision. And he did. There was a lot of damage in the retinas, which is much harder to repair, but she also had cataracts, and those could be replaced. I mean, fixed, you know what I mean. Her lenses could be replaced. So she had some vision left. She stopped being called the tank. She had a complex grief reaction that was prolonged by the use of a chemical restraint. Grief therapy was really fun to do, and she started to make up for lost time. She'd been so focused on this one thing for all those 20 years. So just to speed things along, she identified 2 of the men she lived with as her boyfriends, and they worked it out, you know. It was one of the first spontaneous polyamorous situations I ever observed, and they worked it out and continue to work it out 20 years later. The new ophthalmologist did restore some of her vision, and she still, though, you know, like I said, make enough for lost time. Even though she could navigate just fine, she could see pretty well. Anytime a really good, hot-looking visitor came to the house, she'd do this, oh, I'm so blind thing and pat their butts. and then just wait for the reactions of her two boyfriends that were typically observing all this going on. And her new nickname is the social director, because she has taken in her family's hospitality values and likes to wait on and feed everybody who comes to the house. She illustrates, I think, one of the most important points. Well, there's several important points. First, it's never too late to heal, right? Second, the more we learn about a person, usually the better services we can offer them. Although sometimes, we get people and there's no information, we just have to do what we can. But it's still worth doing, trying to figure that out. And one of the biggest ideas is to try, well, not just try, but avoid using psychotropic medications to treat non-medication problems. Bereavement, for the most part, there's, can be a few exceptions, a little melatonin to help people sleep, stuff like that. For the most part, bereavement is a psychotherapy, counseling, community support issue, not a medication issue. So, 37 years ago, I was working on the medical side of Level 1 Trauma Center medical emergency room when 24 elderly people rolled in with incredibly dangerously low blood sugars. Well, we pull up their records, and a lot of them are paper in those days, yes, antique. And we learned that all of those people were being treated for diabetes at the diabetes clinic. Really good clinic, very high success rate. And these were all really mature people, like I said, people of later years. And so the first impulse on the part of some of the people in the ER was to say, well, maybe they just messed up their treatment, but why so many all at once? That wasn't it, was it? These people have been rock stable for years. Well, it turned out that the diabetes clinic had heard about this fabulous new medication called ranitidine, or Zantac, which is a medicine that is often used to treat reflux. And they were thinking this could prevent inflammation and heartburn in these elderly people with diabetes. So they'd all been started on it, and it took a slightly obsessive-compulsive intern and two other doctors to figure out that class of medicines, the H2 blockers, so Zantac, Axid, Pepsid, Tagamet, those medicines amplify the side effects of other medicines. And in fact, adding Zantac had made their sugar pills, anti-sugar pills, work better, and they all dropped their blood sugars into the nearly lethal range. So that actually is the first scientific publication I was in. That was a long time ago. That was 2 last names ago, one step ahead of the feds. But anyways, the second idea is to subtract before we add, if we possibly can. For these people to be restored, they didn't need more sugar or a change in their stable medicine. They needed to get rid of the extra thing. There's a lot of non-psychiatric medicines that can influence people's behavior and mental health. This is a kind of a partial list, and these are just a few of the frequent flyers that can directly cause agitation and aggression. And you'll see very familiar medicines on here. Some of them, as you'll see in a minute, are also available over the counter. But Dilantin and phenobarbital, notorious. Why most people that have a choice don't take those medicines for seizures. H2 blockers, the Zantac, Axid, that group I just said. Alpha blockers are a type of blood pressure medicine. They can cause depression. They can also cause irritability and aggression and agitation because they mess with your thinking chemicals. Same with beta blockers. ACE inhibitors very, very rarely activate people. Those are medicines like lisinopril or enalapril. Water pills very commonly overconcentrate other medicines and make them more toxic. And nobody does very well when they're dehydrated. I kind of wish that water pills would go away, but that's one of those medicines that still needs to be used from time to time. Pseudoephedrine, or as the great allergist once called it, speed, tends to activate a lot of people, not everybody. Phenylpropanolamine is a old-timey diet pill that used to be available over the counter, still is. It's part of Dristan. Can make people pretty activated, pretty aggressive, and psychotic. Afrin nasal spray, or as we like to nickname it, stroke in a bottle, can cause all kinds of mayhem in terms of people's thinking and neurological function. Steroids and some of the other stimulant asthma medicines. So when a person seems to be having activities of concern or a symptom of aggression, anger, mania, what have you, first stop is what's on their med list that we might be able to get rid of or replace before we start adding psychotropic medicine. These medicines, as I said, can cause hallucinations, delusions, paranoia. Antihistamines at high doses can do the same thing. So a person might take 3 Benadryl to get to sleep and then have pretty severe thought disturbance as a result. And these are some prescribed medicines that can cause hallucinations, delusions, paranoia, and very, very common medicines, many of them. Sleeping medicines that are most notorious for this are Halcion and Ambien, but there's also a bunch of others as well. Antibiotic Levaquin, interferon, which was used for many years as a treatment for hepatitis C. Fortunately, it's not the first line anymore, and a whole bunch of others. So it's nice if at the start we can start by minimizing. But sometimes we're just faced with something that is the result of years and years and years of medicines being added and not subtracted. So Doug was placed in a locked nursing home at the age of 5. We didn't know that story. But Doug was referred to our little clinic taking all of these medicines. And Doug had a diagnosis at that time of profound intellectual disability. I'm kind of amazed that Doug could even remember his own name at this point with all this in their system. Now what? And I've been asked this question. You get a list like this, what are you going to do? He's on at least 2 of every class of medicines we make. And a lot of them are just fighting the side effects of other ones. So this is actually an opportunity to help people regain control of their bodies, because you can start this day. You can go to their medicine cabinet, and I did this with Doug. Ask him, if you could stop one of these medicines today, which one would it be? Doesn't have to have a good reason. There's so much redundancy here. It could be, I don't like the color of this one. All right, we're flushing it now because you said so, which is kind of a nice moment. So that's what we did. And the first thing that Doug wanted to get rid of was lithium. And actually, Doug was probably right. Thought it was side effects having to do with GI symptoms and what have you. But it could have been anything on the whole list. And Doug really looked at me with great skepticism. So we took the pills, the lithium pills, out of his trays, and we flushed them down the toilet. Now, this was many years ago, before we worried so much about the fish. But it was a really nice moment. So then we look at the list and say, what on this list is the most dangerous for Doug? Because most of it was. Sit down with Doug and offer ideas for a plan. He's already been taken away from having any control over his body. Everything from here on out, if we can do it, is going to be along the lines of, Doug, you're in charge now. I think this will affect you this way, and this will affect you this way, but it's up to you to decide. Make a plan and stick to it. And for somebody that's on this many medicines, it's going to be gigantic charts and colors. And if a person can't read the words, then we'll tape pills to the chart and, tape pills to the calendar and then snatch them off when it's time to be done. It's elaborate, but it's also recovery. So, Doug wanted to get rid of lithium, so we got rid of lithium that very first day. Now, the other thing is you'll hear people say, well, you should really reduce medicines one at a time. And others say, yeah, if you've got good enough observers, you can probably do more than that. So again, put the question to Doug, and Doug said, I'm on too many pills. And he further said that he wouldn't live long enough to get rid of all those medicines if we did it one at a time. So the next things that were probably the things messing up his life the most, he decided to get rid of a bunch of them at the same time. Some were treating side effects of others, so they paired together naturally. But Doug decided to start getting rid of Haldol, Stelazine, Cogentin, Vistaril, Inderal, Clonidine, Amantadine, Compazine. And everybody was really worried. Now, what's going to happen here? Is this going to be, total chaos? What's it going to be like? Well, he just, in this phase, just kept feeling better and feeling better and feeling better. The next segment was getting rid of the sedatives, the benzodiazepine sedatives. And we were left with Ativan, Valium, Restoril, and Trazodone were the next ones to come off. And Doug did have seizures, and he received the option to take both of them still or to get rid of one. And this was a clue to things to come. He said, I just don't like the way that Dilantin has changed my face. Made it much more coarse, which is a common long-term side effect. So who do we find underneath all of these medicines? Well, I can't show you all of Doug to preserve anonymity, but Doug came to tell me all about it, dressed like this. And it turned out that Doug had been locked away in a nursing home at the age of 5 because she liked to wear her sister's clothes. And that was what all that chemical restraint was about, was trying to make her not express who she is. She then changed her name to Dougette and lived successfully as a woman for the next 35 years. So I think Dougette explains, like so many people, that when psychotropic medications are used basically to suppress a person's expression, then we're on the wrong track. We end up with escalating doses to ridiculous amounts of medicine. So the question going along with the first idea of, are we using medicine to treat a non-medicine issue, it's very important to say, who is this person really? And is this medicine just being used to fight that? And then also the issue of medication reduction, always a very large amount of discussion. I typically will start by trying to find out why it is the person ended up on this bizarre combination of medicines, and then try and take care of the underlying issues that may have contributed to such a peculiar, set of medicine options. So Orville, 61 years old, looks kind of like Santa Claus, got kind of a manner of Santa Claus, long white beard, bright blue eyes. Orville and his mom had a really, really close relationship. Excuse me. Orville and his mom have this really close relationship. But when he got to be about 20 years old, Mom said, Orville, it's time for you to grow up, be a man, move out, live on your own. So he moved to the house next door to Mom. And they continued to see each other pretty much every day. Orville had, mild to moderate intellectual disability, and he needed next to nothing in terms of services and supports, except for people to help him find his Santa costume every year because he was the most popular Santa around town. Well, after he and his mom, who were very much in each other's lives in a really good way, one of those really good ways, when Mom got into her upper 80s, she passed away after a short illness. And Orville went to his doctor and said, Doctor, I can't sleep very well. I don't feel like eating at all. And I've been checking this out on the book. He had some medical books he liked to look at. I think I got depression. And the doctor said, well, I can see that you're having trouble sleeping, so I'll give you some Mellaril to help you sleep. It's a very old story, very old drug, very toxic drug. Does not treat depression. Next thing that happened was Orville didn't feel any better, but he did have a heart attack, which is a complication of the use of Mellaril. The next recommendation from this same doctor was, well, I don't see why a guy with this IQ gets to live on his own anyway. So, and since he's had a heart attack, we should put him in a nursing home. And obviously, he doesn't have any use for cardiac rehab. So, very, very dangerous situation of medical discrimination and non-treatment of the original problem. So if we're standing at his side, at Orville's side, and we're going to try and advocate for him, are we going to be firm and polite? If that doesn't work, are we going to be really firm and not very polite? And if necessary, are we going to turn into table-pounding banshees to make sure Orville gets what he needs? You bet we are, because it is a matter of life and death, isn't it? So Orville finally got properly treated for depression and bereavement, and he had a full recovery. He lived to be about 90 years old, still playing Santa every December. Really important idea, we have to keep reminding people of it. Treat causes, not just symptoms. If a person has pneumonia and a fever, you don't just treat the fever, right? You got to kill the bug that's causing the pneumonia. There's a lot of other things in the psychiatric realm that follow that sort of same general idea and pattern. So what are some specific conditions? Well, let's talk about Ellie. Ellie's a 96-year-old who likes sports. She referred herself to me because she knew that I'd done some work with a couple of her housemates. She had a couple of lady housemates in their 50s whom she called the girls. And they'd done all right. So Ellie thought I might be worth talking to, and she has, who knows, mild to moderate to severe intellectual disability, depending on who you read, but I don't think it really gets in our way much. She said, Ruth, actually she said, Ruthie, she can call me anything she likes at 96. She said, Ruthie, I need more pep. And the people that provide support to her and the girls and the baby, they decided to take on a housemate in her 20s, and they called her the baby. They were all like, you're 96, you have a pulse, what are you complaining about? And but they respected her. She said she wanted to see the psychiatrist because she wanted more energy. Okay, so tell me more. Well, I need more pep. Well, do you have something particular in mind or just kind of in general? She said, yeah, I got a 10K race I got to run with the baby. The gal in her 20s was signed up to run a 10K, and Ellie was going to run it with her. She said, Ruthie, I know how to train for this, I just don't have the pep for it. Now, you have heard the story of the 98-year-old man with the sore knee, right? Goes to his doctor and says, "Doc, I have a sore knee." And the doc says, "Well, you are 98 years old." And he says, "My other knee is 98 and it's doing fine." Always in the back of our minds, wait a minute, don't make assumptions, right? So I said, "Well, have you noticed any other ways that you have less pep, other than not having the pep you need to train for this race?" She said, "Yeah, not sleeping too good." Little bit interrupted, huh? Now, she doesn't take any medicine. She's in disgustingly good health. I mean, she's one of those people that you study every organ of her body and they're all working perfectly. Makes you sick, really. 96? And I mean, is that like, well, that aside, she didn't have any health issues other than needing more pep. Didn't have an anemia, she wasn't low on any vitamins. She didn't have any habits like drinking a quart of tequila every day. But she didn't have the energy she wanted for the things she wanted to do. And she wasn't sleeping very well. And even though she ate fine, she didn't feel much like it. I usually like my grub, Ruth, but I'm not liking it so much. Oh, tell me more. What else is going on that's different? Well, I dumped my boyfriend because didn't feel like having sex anymore. She lost her sex drive. So on the one hand, the people providing support to her are like, seriously? But then let's hear the story. Loss of energy, loss of interest in activities, sleep disturbance, appetite disturbance, interfering with preferred function. If she were 35 years old, nobody would blink before they diagnosed major depressive disorder. Yet because she was 96, there were people that thought they should just accept that as normal for her age. So in fact, are we going to do that? No. She met criteria for major depressive disorder. Now, is it okay to just ignore that? Does untreated major depression impact people? Yeah, it shortens people's lives in all kinds of ways. So these are some of the standard criteria for major depressive disorder. Depressed, irritable most of the day, loss of pleasure, loss of enjoyment, unintentional weight. You've all heard these criteria. They're listed everywhere you go. Loss of energy, worthlessness or inappropriate guilt. She didn't have that, and I was glad she wasn't burdened with that one. But she was feeling like it was really hard to decide what to do next. Easily mistaken for dementia, but in fact is a pseudo-dementia. And she didn't have suicidal thinking, but she was starting to feel a little hopeless about, okay, what's next if I can't even train for a race? Proper diagnosis of depression it's not the same as a grief reaction. And there's ways to make that distinction. She had not suffered any extreme losses, except her sex drive, which she was missing very much. And it wasn't effective of any drugs, alcohol, or other health problems. And these are some of the different medicines that are often used to treat depression. The main thing is to find one that does the job for a person and is minimal in side effects, and we've got so many options. It's not reasonable for a person to just go untreated. A couple of them have a couple of peculiars. For example, Cymbalta or duloxetine, it's kind of hard for people to taper off that once they've been on it. It sometimes helps people, though, that also have pain along with depression. Couple of them help people gain weight if they need it, particularly mirtazapine, also called Remeron. Augmentation medicines are things we can add little doses of to make the antidepressant work better, but not multiply side effects. And we usually can't use lithium, Wellbutrin, and trazodone at antidepressant doses, just for all kinds of physiologic risk factor issues. And I think everybody's heard of Prozac, Zoloft, Paxil, Celexa, Lexapro, right? And those are probably the most commonly used medicines for treatment of depression and treatment of generalized anxiety. There's some newer ones. They're blended agents. They have different advantages and disadvantages. I have noticed that for people that have Medicaid type payment schemes, they're often not offered these medicines because there's a couple of hoops that you have to jump through to get them. But for some people, it's certainly worth the trip because these often have a more favorable side effect profile. And then some of the more important new treatments or old treatments that keep getting resurrected. One is transcranial magnetic stimulation, where it looks like something from an old science fiction movie, where people get a headset that stimulates certain parts of their brain, and it seems to really lift depression in a non-pharmacologic way for some people that medicines are just haven't been a very successful option. The vagus nerve stimulator, it's used for seizures, and it was discovered that it also, for some people, treats depression. Electroshock therapy or electroconvulsive therapy is got a terrible reputation, but in fact can be a life-saving treatment offered properly to the correctly selected individuals. And ketamine infusions are kind of the newest kid on the block in terms of non-mainstream treatments, and they're a little bit mixed in terms of reviews. Ketamine, as you know, is an intoxicant and an anesthetic, and ketamine infusions were used to basically lift the spirits of people that are deeply depressed. The issue, unfortunately, with ketamine, as with other intoxicants, is that the person may feel better temporarily, but they can't function while they're under the influence very well, usually, not always, but usually. And a lot of practitioners seem to be saying that once people have a few treatments and then the treatments wear off, they're more depressed later than they were to start with. So there's still, I think, a lot of refinement and fine-tuning that's going on in terms of the role ketamine or ketamine is going to have for treatment of severe depression. And this is one of the advertising shots of the transcranial magnetic stimulation gadget. And it looks just like that, and some people just swear by it. Does not tend to cause, medication type side effects. Some people do get headaches from it. There's a lot of non-medication stuff that can augment the treatment of depression. I was lucky enough to practice in a couple of states where it was really common for an MD like me to practice alongside a healer in a different spiritual or cultural tradition, and we just worked together to double team the person to help them recover in all the ways we could think of. Psychotherapy augmentation often helps. Exercise, if the person has the energy for it, but trying to push exercise on somebody who's deeply depressed can have terribly paradoxical reactions. Nutrition, music, movement, dance, pleasure, vices in the right quantity, doing fun stuff. However, when depression is at a certain depth, these things, in fact, will have the opposite effect. It depends on the severity of the depression. In fact, you can watch this on some of the functional neuroimaging, where something that ordinarily will give a person a pleasure circuit, that circuit will be in fact, shut down. And so that incoming stimulation that would ordinarily make them happy actually gets diverted into the pain and depression parts of the brain. And then opens back up when the depression is relieved. It's a really diabolical condition. And it's hard for people that are trying to cheer a person up, right? You try and help and nothing lands, or you get a paradoxical reaction, an angry response. And the other part of that is that people with depression, if they express what's going on with them, they may be able to hide it in some situations, but they tend to inflict the worst of it on the people they love the most. So that just is why untreated depression not only injures people, but can also blow up families and other kinds of important collaborations. But Ruth, I hear this news item that says psychotropic medications don't help any more than placebo, which is a fake pill like a sugar pill, or counseling, or just a good exercise program. Is that true, that psychotropic medicines don't really add anything? Well, I think it's because a little bit of a kind of a down mood is not the same as major depression. There is some evidence that for people with very mild depressions, all kinds of things work pretty well. But for the people with the severe incapacitating depression, withholding medication cannot be justified. It's just too unsafe. So Ellie, 96 years old, there were only a couple of medicines to choose from in those days. She wanted to run that 10K race alongside her 25-year-old housemate. Lots of eye rolling going on, but not in a mean way. It's just people couldn't believe what they were hearing. Well, it turned out that Ellie had been a marathoner in her 60s. Oh, which probably explained a thing or two. She decided to try Zoloft, not a very high dose, but an adequate dose for a tiny little woman her size. She had a full remission in symptoms. She got herself a new boyfriend. She needed somebody, in his 70s so he could, keep up. Got back to all of her usual activities, and she, however, did not run that 10K race in 6 months. It took her 8 months to be trained up enough to do it, and she beat the snot out of her 25-year-old housemate. She was a powerhouse. Last I heard, Ellie was 104 years old and was spending her spare time teaching aerobics to old people. Like, who's that, right? Idea number 4 is that we ought to be open to all the possibilities and all the people. Otherwise, we'll prematurely shut out treatment options. So Larry is a 46-year-old man, works as a custodian, and he's referred for evaluation of amazing masturbation. Extraordinary masturbation. 25 ejaculations a day. And they were really ejaculations. How did people know this? Well, he did seek privacy for this personal sexual activity, but then they would be able to find out later, which is all kinds of euphemistic reporting in his chart. In addition to those 25 ejaculations a day, Larry was taking 1,400 milligrams of an old medicine, I mentioned it before, called Meloril. It was supposed to reduce his sex drive. Imagine if he wasn't taking it. Oh. Unfortunately, back in the day, he had survived back in the day, it was very common to give anybody with an intellectual disability who had evidence of a sex drive, they were given medicine to try and suppress that, and which is horrible, of course, and led to situations like this, where every time he had an episode which was usually about a week long, where he was basically masturbating all the time, he'd get a higher dose of Mellaril. And as they looked at the calendar, they realized whereas originally he would have a phase like this, starting 20 years ago, every 6 months, now he's having them every 6 weeks. And people were saying, well, this isn't safe, and second, this isn't how he usually is. And that, sometimes when people hear this story about this amazing capacity for masturbation, their first question is, so what's the problem? Which you could get that, why people would go there. But they said, well, number one, while this is going on, he doesn't sleep at all. Number two, he loses interest in everything else. Number three, whatever boyfriend he has at the time ends up breaking up with him. So each time he has a phase like this, it kind of ruins his life. Now, if that's truly something he's choosing, okay. Well, how does he look? Really happy. When this is all going on, he's a very happy man. Okay, so it's probably not post-traumatic. Some people have PTSD symptoms of this type. It's not PTSD. And he doesn't look anxious. He just looks really happy. And the other thing, and this was the thing that convinced us we need to really, really look into this, is that after he has a week like this, he crashes and he's miserable for days. Can't get out of bed. Okay, now we're getting it. Why anybody thinks this is a problem. So, where's some places we can get information to help inform us about what might be driving this? He communicates without speech. His facial expressions are very, very helpful. He's happy, he's expansive, he's full of joy during these spells, and then he's practically immobilized after the crash. Well, do we have any family psychiatric history? Would it be interesting to know that his mother, father, siblings, aunts, uncles, cousins, and grandparents all have bipolar disorder, and all had their first manic episode in their mid-20s characterized by hypersexuality. But when it was Larry's turn, because he had a developmental disability, somebody just thought he had an inappropriate sex drive. And so he's had to wait now 20 years to get treated for bipolar disorder. What are the criteria for bipolar disorder? This is a manic episode. Manic episode is pretty classic type of a finding if a person has the typical happy manic episode. Not everybody does, right? There's a point at which a manic person becomes extremely miserable. They can't stay still, they can't get comfortable, or they may have what's called dysphoric mania, which we'll talk about in a second. People have all the energy in the world, they're more talkative, you can't interrupt, their thoughts are going 1,000 miles an hour, they're distractible. They keep trying to do more things and more things and more things. Let's start a new business, let's buy 3 new cars, let's get 4 new sex partners. Really, really extreme for that given individual. And people kind of lose their inhibitions, so they often get caught up in stuff that could get them in trouble that they might not otherwise engage in, like too much spending or too much gambling or a lot of sexual relationships with unknown people and no protection like that. This can be caused by certain drugs of abuse, so we always have to be on the lookout. There's certain health conditions that can cause a manic episode. Most notoriously are steroids, but there's others as well. And for people with what's called bipolar disorder type 2, they don't develop a manic episode unless some clever psychiatrist, such as myself, puts them on an antidepressant and triggers it. So this is a long list. This is medicines that can be used to be treated can be used to treat bipolar disorder in pretty much anybody. We tend to avoid lithium and Wellbutrin in people with IDD because of the difficulties of monitoring and seizure risks. Probably the most common one that's used in general practice is Depakote, valproic acid, highly promoted for this particular indication. However, there are other medicines that work at least as well that have nicer side effect profiles. Trileptal is a cousin of Tegretol, can be very helpful, particularly for people that just don't necessarily like all the effects of Tegretol. Topamax is kind of cool. Some people really like it because they lose weight on it, which is different than almost all the other medicines we offer people. Lamotrigine is the most favorably reviewed and researched medicine for young people with bipolar disorder. We can often get more than one benefit if we use certain medicines. Many of these medicines also prevent migraine headaches and treat seizures and help attenuate the symptoms of post-traumatic stress disorder. Because, like we talked about in other seminars, all this stuff kind of lives in the same very delicate piece of brain real estate, and sometimes treating one can help relieve the other, and so on. Non-medication aspects of treatment of bipolar disorder, probably the most important is sleep preservation. Also really important, I think, to educate the individual and others is that many of these conditions contain perceptual gifts or insights that are not available to the ordinary population. And there's many kind of famous creative people or famous entertainers that help describe this part of having bipolar disorder. What happened with Larry? Well, Larry got treated with the same mood stabilizer that helped every single person in his family. He didn't lose his sex drive. We very gradually took him off of the Mellaril. And from that time on, he had no further spells of this type. He was able to go back to his job and keep it. He was able to get with the nicest of all of his boyfriends and stay with him, and basically enjoy all the different aspects of his life without having it all blown up every 6 weeks with this type of a manic episode. And if we weren't on video, I'd be showing you his picture. He really wanted this story to be told, and so does his long-term boyfriend. But I wanted to make absolutely sure he knew what that meant. He communicates without speech. I was pretty sure, but I wanted to make absolutely sure. So I got a little seminar together that was people that all kind of knew his story anyway. And I have him sitting there in the front row, and I start the story the same way. I look out at the group. I said, Larry, 46-year-old man, works as a custodian who's referred because of amazing masturbation. And I'm looking at Larry like, is this all right? And he held up one finger. I said, all right. He got up, took a look at everybody, and took a bow. So I guess he was okay with it. What is the most common psychiatric condition underlying symptoms of aggression in persons with intellectual and developmental disabilities? Now keep in mind, the most common medicines that are given to people with IDD who are aggressive are antipsychotic medications and Depakote. However, the most common psychiatric condition that's in fact really going on is depression. Now, what do antipsychotic medications and Depakote do for depression? Nada. They just add side effects. So the person might be slowed down and sedated, right? Chemical restraint. But we won't be treating cause if that's the medicines that are always being given to people who have symptoms of aggression. A couple of things that people have educated me about over the years that it's not necessarily written down anywhere People have said in the past, oh, you can just stop the Prozac or you can just stop the Zoloft, it'll be fine. But in fact, there is a withdrawal syndrome when people stop their antidepressants. It's not horrific or life-threatening like stopping a opiate medicine, but it's important. Paxil and Cymbalta are the hardest in terms of withdrawing from the medicine. Venlafaxine or Effexor is a close third. Sexual side effects are not that uncommon, and there's a bunch of different ways to treat those, so nobody should have to just live with it. I believe I've observed, and I think some real big experts in this area have observed that when people kind of stop taking their meds and won't tell you why, this might be why. So, which is why I ask pretty much every patient in every visit, hey, is this medicine getting in the way of your sex life at all? Or how are things going on in the sex department? Basically offering people the opportunity to tell me so I can offer them some ways to fix that. Sometimes SSRI medicines, and that's the Prozac, Paxil, Zoloft group, will cause a person's sodium to drop. And there's also a phenomenon called a serotonin syndrome. And it can be very serious, it can be life-threatening, so it's really important that people know the symptoms: flushing, diarrhea, confusion, inappropriate, meaning unintentional urination, and so on. Some conditions almost always require treatment in a continuous way. Years and years ago, when medicines were mostly being used as restraints, people would advocate what's called medication holidays, where they just stop all the medicines. And I kind of get the logic behind that. Often people were on, buckets of medicines without real clear benefits. However, if a person is stable on their psychotropic medication, it's almost always a bad idea to stop the medicine. People will ask this. Sometimes people will have one episode of depression, they'll get relief, and after 6 months or a year or so, they'll say, well, can I go off the medicine? And there's no hard and fast rule. Most of us will counsel people that there is a chance depression will come back, and when it comes back, you might need to look into different treatments. This treatment may not work as well. However, it's ultimately, of course, up to the person, but that is the sort of counseling I would offer them. People with bipolar disorder have it a little harder. People go off their mood-stabilizing medicines, or they miss a couple nights of sleep that will often trigger a cascade that can last for months. It's really, really hard on people. So let's talk about Ahmed. Ahmed's 48. He's not sleeping all night. He's got lots and lots of energy, lots of ideas. He can't sit still. Gets real angry when people say, just settle down. He makes lots of vocalizations, and he's not interruptible. He doesn't communicate with speech. He communicates with, obviously, gestures and sounds, and with his body. So you hear a story like this, and the very first thing you think is, well, this looks like a manic episode for all the world. And that probably should be the first thing somebody thinks, but he gets treated for presumed bipolar disorder, and he doesn't do well. In fact, he gets worse. So do we just keep cycling through treatments for bipolar disorder? No, then we got to get more information, maybe stuff we should have gotten the first time. Like, it turns out he has an aunt on one side and a cousin on the other side of the family who have a condition called G6PD deficiency, much more common in people of Middle Eastern heritage. The other name for it is Fauvism. And basically, people with this condition will have these symptoms and many others in response to certain artificial scents or other kinds of volatile compounds. It's a completely metabolic syndrome treated with environmental changes and with dietary changes. Yet the man I'm talking about, and this is easily tested with blood tests, this man, he waited until he was 48 years old to even get tested for this condition, even though it ran in his family. It's very genetic. And it was because, as we've talked about in other seminars, people kept doing something that was not working because they were sure it should work. There's a certain subgroup of clinicians who are being encouraged to diagnose everyone they see with bipolar disorder. I will spare you the politics. In reality, this condition occurs in about 9% of people with intellectual or developmental disabilities who have mental health issues. Plus, there's also the encouragement for clinicians to diagnose everybody as being on the spectrum or having some subtype of autism spectrum disorder. Really important that, if a person's doing beautifully well, we don't need to fool with their diagnoses, right? But if they're not doing well, it should be one of our very first steps is to reevaluate diagnosis. Sherry is 23 years old, has a horrific trauma history. Everything you could imagine, starting with when she was a toddler, her mother tying her and her siblings down to the furniture and lighting the house on fire in an effort to try and burn them to death. Mother went to prison for this. It was just ghastly, and this woman has marks on her body from this. And everybody who's worked with her says, well, all this other stuff she talks about, it's got to be trauma related, right? What's that tunnel vision thing we talk about? It turns out that she has had auditory, visual, and tactile hallucinations for at least 10 years. And they've always been dismissed as manipulative behavior or post-traumatic. Yet, the emergence of hallucinations and delusions in the early teen years, what's that a textbook for? It's a textbook, obviously, for schizophrenia. And when people really do have schizophrenia, they do better in all the areas of life when they get proper medicines, if they need medicines at all. We did talk earlier about recovery model, and we also talked about schizophrenia and bipolar disorder in other seminars. So it's not 100% sure that a person will need medicine for a long period of time or even a short period of time, but they should certainly have the option. And this gal we just talked about, she finally got adequate doses of antipsychotic medication. Hallucinations went away. Does it matter? Well, she doesn't have those hallucinations anymore. She doesn't damage herself anymore. She's got a boyfriend, she's got friends, she's got 25 hobbies. It kind of makes a difference, doesn't it? These are some of the medicines that are pretty commonly used. I have favorites. Most psychiatrists have favorites that they use more than others. The atypical antipsychotic medications were in fact new when I was in training. So that's Seroquel, Zyprexa, and Risperdal, and Geodone. At the time when, you're going to love this, when they were first provided, they were supposedly free of all side effects. We know better than that, don't we? And they were supposed to take the place of those bad old first generation antipsychotics that had all those bad old side effects. In fact, they all have side effects, some worse than others. The first generation medicines still have some utility for some people. And the ones that you'll see used most often would be small doses of haloperidol, Haldol, not high dose. High doses are typically not good for people. And middle side effect medicines like Trilofan or even Stelazine when you can get it. Latuda is pushed for bipolar depression with psychotic features, but it's not my favorite, and everybody has their story, right? But most people I've worked with who take Latuda get some rage and anger out of it that isn't good for them. How long does it take for an antipsychotic medication, except for one? All the other antipsychotic medications take how long to alleviate hallucinations or delusions? And you'd think it must be really fast because of people that are very psychotic getting injected with them as soon as they arrive in the emergency room. Well, it turns out the antipsychotic part, the alleviation of the hallucinations and delusions, that takes 3 or 4 days. There's a whole bunch of side effects sedation part, and that's typically, I think, the reason why people are getting those injections right away. There is one antipsychotic medication, if given properly, alleviates hallucinations and delusions in a matter of minutes. And for some reason, it's not used very much. I think because it tastes crappy, but it's called asenapine or Saffras. And for the people I work with who have schizophreniform conditions, if they need something from time to time to alleviate hallucinations, this is what I offer. And it seems to be very effective as long as people know how to take it properly. It has to go under the tongue or be in a patch. If it's swallowed like a pill, it doesn't work as fast. So idea number 5 is the person's diagnosis correct? Like that gal with the terrible trauma history, she had PTSD, but she also did have schizophrenia. Is the diagnosis complete? And most of the people we work with have more than one condition, right? So, Depakote, Depakine, Divalproex, valproic acid, the company that makes this medicine has been enormously successful in promoting this medicine for basically everything in psychiatry and neurology. Why do I make such a big deal about it? Well, I told you a little bit about that earlier with the hemorrhagic pancreatitis. There's a couple of other things too. One is the carnitine issue. Carnitine, as you may know, is an amino acid your body needs for muscle strength and mood stability. And the thing about it is that if you get low on carnitine, you start to wobble and you start to get very, very tired. And if you let carnitine deficiency go on too long, it starts to affect your heart and your ability to breathe. Carnitine is reduced by Depakote. And this has been well established in the pediatric neurology literature. So it's not a new idea at all. And they talk about the carnitine supplementation plans for children and adults who take Depakote for seizures. So I tried to publish a bunch of cases of adults with psychiatric conditions that needed carnitine. And I thought the pharmaceutical company would be really kind of pleased about that because it's another way for people to keep taking the medicine they make. But that hasn't been the case at all. So I talked to the guy who's like the superstar of carnitine. His name's David Coulter. He published all the neurology articles about carnitine and Depakote. And he said that in his patients with psychiatric overlay, that he saw exactly the same thing. So the upshot of that is that for people that we work with, we should be checking carnitine, especially if they develop problems with wobbly walk, incontinence, or extreme fatigue while they're taking valproic acid. And I need to highlight this because valproic acid is so incredibly popular and highly promoted. We already talked about hemorrhagic pancreatitis. So idea 6 is in persons with IDD, the side effects of medicines tend to occur more frequently and they tend to be more bizarre and more serious. Did I ever tell you how valproic acid, Depakote, was discovered? Well, see, there was this guy working at the pharmaceutical company who was studying chemistry, but his job was to wash the test tubes in the lab. And he was washing the test tubes with this fabulous solvent called valproic acid. And as he thought about the chemistry of valproic acid, you know, the stuff he was using to wash out test tubes, He thought, oh, this would be fabulous for shutting down excessive brain activity. And in fact, it is. It's a solvent that's used for cleaning purposes. So it's sort of the pharmacologic equivalent of sniffing glue. That might not be very nice of me to say, huh? Nina is a 46-year-old woman with schizophrenia and seasonal noncompliance. Does this mean that she refuses to agree to autumn? Or what does that mean exactly? Every autumn, she would stop taking her medicines for schizophrenia. And she'd land in the hospital, cycle, back out again. And this went on for years and years. And so everybody's saying, well, what happened in fall? Obviously, nothing happened to me. I'm fine. Nothing happened in fall. Fall's fine. No problem. Well, why is it you say your medicine stopped working? Because of the new hallucination. Well, what's that? It's a hallucination of burning. Okay. What's burning in this hallucination? Well, you know. No, I don't. Well, what does it remind you of, this type of burning? Well, on Labor Day, 10 years ago, I saw my brother burned to death in a fire. Beautiful tunnel vision of a person with schizophrenia. People asked her every way they could think of, did something happen to her? And to her way of thinking, that didn't happen to her. Poor thing. So even though she clearly had schizophrenia, she also had pretty severe post-traumatic stress disorder. And the fact that part of the flashback was an olfactory flashback really confused the diagnosis because it just seemed like another hallucination. She did really well. James was a 50-year-old ex-football player who had delusions and hallucinations. And every time he got on antipsychotic medication, he got worse. There were people with schizophrenia in his family. And so everybody knew when he got to be about 18 and started to have hallucinations and delusions, they knew that it obviously must be schizophrenia like everybody else in the family. Until he was scanned, and it turned out he had chronic traumatic encephalopathy from football, and that's what was causing the hallucinations. Totally different treatment strategy, but it took years to get there. He was a very good example of somebody who's getting the same thing that didn't work for decades because it should have worked. Susanna is 43 years old, referred because of bizarre occult delusions. And she was referred to me because they said, she's got some kind of personality disorder. I mean, look at all that stuff she does to herself. She had marks on her body. And she claimed that these people in this cult had carved things onto her body. And this was in a rural part of Colorado, and there was a lot of geography that was occupied by who knows who. So I said, well, I think that we should look into this. No, don't be stupid. You don't give in to that. She's just, leading you around, blah, blah, blah. Well, and she did that to herself. She put those marks on herself. I said, well, some of those places are places she can't reach. Yeah, well, she just got one of her other character disorder friends to do it for her. We're not going to be bothered with this, blah, 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 blah. Long story short, she was being pursued by a cult. Cult members tried to kill her by burning her to death. She survived, and it turned out that the people that kept dismissing her were in the cult. Important point for me is that, the first time you hear a story like this, you might think schizophrenia or some other kind of psychosis, but it's never really a bad thing to check out the story. Some of the most bizarre stories turn out to be true, and even in the stories that are absolutely not true, there may be a kernel of knowledge in there, or wisdom or insight that would be worth paying attention to. Why does this person have this type of hallucination? If a person has hallucinations, consider delirium. Consider the overlap with people with post-traumatic stress disorder. Don't forget hallucinations in other senses besides auditory and visual. And don't forget Bonnet syndrome, or release phenomena, which is if a person is losing a sensory faculty, one of the manifestations of that can be hallucinations in that sensory faculty. So the treatment might be to repair cataracts, not start the person on antipsychotic medication. Severe anxiety can cause a brief reactive psychosis that should not be treated with antipsychotic medication. And there are many other conditions that can produce hallucinations and delusions, but they won't respond well to treatment with antipsychotic medications. Bobby is a 26-year-old flower enthusiast who was referred for evaluation of extreme self-mutilation. He had injured or destroyed every surface of his body. Scars from head to toe. He was originally thought to only do this during waking hours, but it turned out he would get jagged objects so that he could tear up his insides while he was sleeping. No matter what he was doing, it was like a stopwatch. Every 3 to 6 minutes, he would do something painful to himself. It was clearly an addiction. We didn't get that to start with. However, this was the part, it was one of those great, wow, people will tell you things. The staff working with him said, yeah, Ruth, he likes it. He likes it. And it was true. When he would hurt himself, he looked intoxicated. His pupils would constrict. And people that had worked in other parts of healthcare said, yeah, he looks like somebody who's just been injecting heroin. Well, is there a way to do that to yourself that's natural? In fact, there is. Now, most people, when they get a Vicodin or a Percocet or a heroin or an OxyContin, don't really like the way it feels. So they only use it for that short period of time. But there's a subgroup of people that get addicted if they try opiate pain medicine. Well, that applies also to people's endorphins, which are much, much more powerful than any pills we could make. And some people don't just enjoy their endorphins, but in fact become addicted to them and need ever escalating doses. And the way to do that is to hurt yourself, get in fights, do scary stuff, and that will rush the endorphins throughout your body. If you want to test somebody to see if they've developed an endorphin addiction, the way to do that is to do a spinal tap and measure the level of endorphins in the brain. There's a normal amount, and then there's what Bobby had, which was several thousand times the normal amount of endorphins in his brain. So, in fact, he had an endorphin addiction. And I think we see this in other people, greater or lesser extents, depending on the self-harm activity. This is a situation where, carefully, we have to withdraw the person from their own endorphins without harming them or making them more miserable. This is not an easy task. You just can't tell a person to stop doing it. One gal I worked with who had this problem, somebody decided what they would do is just completely isolate her body and restrain her body so that she, as far as they knew, she couldn't harm herself. She dislocated bones, she bit off her tongue, she did all kinds of things to herself to keep that endorphin rush going. Turns out it can be, you can withdraw somebody. First, we find out if the person has ongoing pain that needs treatment, because sometimes that's how it gets started. Oh, wow. And like for Bobby, somebody had done a tonsillectomy and not given him pain medicine. And because he has profound intellectual disability, blah, 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 they didn't think he needed pain medicine. And that was his first dose of pain. And he got to liking it, apparently, after that. People will look like they are intoxicated on an opiate, constricted pupils, intoxicated, constipated, the whole thing. The injury, the self-harm, occurs right on schedule as soon as their level starts to drop. And for all of the people we studied with this, they had a family history of addiction to narcotics or alcohol. I think that's interesting. It's like that's how the gene affected these people. So to withdraw him, we placed him on naltrexone. He needed a big dose. And then we gave him medicine to help him through the withdrawal. And we got our extra consultation from people that worked in a heroin detox center. And they had the best ideas, and, you know, certain medicines, certain non-medicines. Oh yeah, you're gonna see this. It was pretty fabulous, the kind of help we got from those people. Substance abuse conditions in people with IDD are a little different than in the general population. For example, what is the most commonly abused hallucinogen in people with IDD? Well, a lot of people would say, well, how about marijuana? It's, you know, it's not even illegal a lot of places, but in fact, that's not the case. The most commonly misused hallucinogen is inhalants, and they're incredibly toxic and addictive. So sniffing glue, paint, gas, things of that nature. People will present with unusual symptoms in association with the chemicals they might misuse. And there's also the factor of involuntary use, that is, caregivers drugging people to obtain compliance with abuse or just to obtain compliance, or what have you. I just got a referral of somebody whose family members gave him a combination of oxycodone and insulin to sedate him. Yeah, poisoned by his family. And AA models can be very helpful for some people, but there's other models like the Eagle Lodge model and some of the others that are a little bit more relationship-based, strength-based, in a more health-promoting way that some people find more useful. Fortunately, AA can be very good, very inclusive, can be just the right thing for people, but there's a bunch of other options as well. Obsessive compulsive symptoms can be a part of a bajillion other health issues. I want to mention this only because sometimes when people see repetitious activities, they think either, if they're in the DD system, they think the person has autism, and if they're in the mental health system, they immediately conclude the person has obsessive compulsive disorder, when in fact, it might be neither. And I just want to mention, these are some of the many, many, many conditions that can cause a person to appear to be very obsessed and compulsive. So it's nothing wrong with, you know, trying OCD medicine to start. But when that doesn't work, we've got a lot longer list of stuff we got to figure out if it's going on with the given individual. If the person has compulsions, let's take a review of all the possible causes. So idea 7, if a medicine combined with appropriate non-medication supports is not helpful, we usually have to go back and reassess diagnosis or diagnoses. What did we miss? Because it turns out, it says Professor Gallagher and his controversial technique of simultaneously confronting the fear of heights, snakes, and the dark. It turns out most people have a lot of stuff going on, not just one thing, right? The trauma that people experience, the stress they experience, will unmask a variety of conditions, cause conditions, and produce a lot of complexity. one of the things that can really help guide us to keep us from getting too far down the road of doing things that don't work because they should is if we gather data. And if you don't like the data that are being gathered, do better. I want to mention this particular syndrome. You'll see this kind of wide-eyed, wonder-filled child, about 2 years old, kind of funny-looking ears, a little bit low set, tilted backwards, just like one of these sort of wide-eyed kind of interesting syndromes. This is a behavior analyst. This is Steve when he was 2 years old. This is, the beginnings of his career as a behavior. I know, isn't that a great one? He usually puts this right next to his PhD diploma. This is where behavior analysts, who are the experts at gathering useful data, can really help us not get off track. Say, yeah, we were brilliant in our deductions that led to this particular medication suggestion and idea, but here's what the evidence is. Nothing's better. Or if something's better, we're not measuring it, and we better, because we got to pay attention to what's going well. But so don't think about a discussion of medicines as an exclusion of the non-medicine professionals. In fact, they may have, if anything, a magnified role in that particular situation. Knowing the difference between health-promoting medication use versus chemical restraint is really important. And I cannot overstate the harms caused by chemical restraint, particularly if it's ongoing. It says, what the hell was I supposed to do? I've been declawed. Boom. Or, hey, bucko, I'm through begging. Suppressing, restraining doesn't end well. Taking away a person's power can have completely unpredictable outcomes. Let's summarize the ideas, right? Let's not use medicines to treat non-medication issues. Subtract before we add, if possible. Treat causes, not just symptoms. Be open to all possibilities in all people, no matter how well we think we know them. Make sure diagnosis is both correct and complete. And be aware that side effects are a much bigger issue for people with IDD. And most of all, if a medicine isn't helping, let's go back. What did we miss? Where can we get more information? And what can we offer that's not just more of the same? Because then we find that people refer to us as kegs of gunpowder ready to explode turn out to be, in fact, a collection of fine wines waiting for an opportunity to be opened, to breathe, and to be appreciated. Thank you for considering this way of offering psychotropic medicine.